What's up, future respiratory therapists? In this video, we're breaking down another critical thinking practice TMC question, and you don't want to miss it. Let's dive in. All right, so lots of good feedback on my last breakdown of a practice TMC question. So we're going to kind of keep that theme going for the next couple of weeks. I know I got a lot of people preparing for their TMC exam coming up in April, maybe June. If you're not even thinking about your TMC and you're early on in your journey to being a respiratory therapist, then don't get me wrong, there's still a lot of value in these videos because a lot of the questions that you're going to see on your exams are going to require you to critical think. They're going to require you to pay attention to details. This video is all about breaking down and recognizing what details are important and what's not. So, without further ado, let's jump into this. What we have here is a 36-year-old male in the ICU. He's intubated. He's got an 8.0 endotracheal tube with at the 22 centimeter mark at the teeth. He's on the ventilator. He's got a volume control with a tidal volume of 450, a rate of 16 breaths per minute, a flow of 50 liters per minute, FiO2 of 60%, and a PEEP of 7. PIPs are 36 centimeters of water pressure. Your plateaus are 30 centimeters of water pressure. Your ABG, 7.33. CO2 is 47. O2 65 with a SAT of 92%. You get called to the patient's room for a high pressure alarm. Which of the following could be a potential problem? This is the most important part of this scenario. Why? Because that is the question. Again, you always have to know the question before you can answer it. So there was a lot of information up here. Vent settings, endotracheal tube placement and size, ABG. And remember, don't fall into the trap that my 20-year vet self does. I look at this and go, oh, I bet they're going to want me to fix this blood gas. But they don't, and they didn't. They asked us what could be the potential problem causing the high pressure alarm. So that really simplifies this question to where it's no longer about the ABG, it's no longer about the FiO2 or the PEEP. It's really only about volume control. We know that in volume control, our volumes are set and our pressures will vary. Now, if that is true, then we know that anything that affects airway resistance or compliance is going to cause our pressures to go up in volume control. So let's look at question number 1. Pneumothorax. Of course a pneumothorax will cause your pressure to go up. Remember, we are ventilating 2 lungs. 2 lungs being ventilated, right? If one of them collapses, then now we are ventilating this one lung with this 450 ml tidal volume, and of course your pressures are going to go up. So yes, a pneumothorax will cause this. What about obstruction of the endotracheal tube? 100%. You have an endotracheal tube in this airway. If that endotracheal tube becomes obstructed in any manner, then yes, your pressures are going to increase. It's going to cause an increase in airway resistance, causing your pressures to go up. So yes, it could be an obstruction of an endotracheal tube. What about a mucus plug? What if you have a mucus plug that develops right here in the left main stem? Then all of the air is going to go to the right side of the lungs. And that's going to cause, just like a pneumothorax, your pressures to go up. And what about an accidental advancement of your endotracheal tube? If this endotracheal tube advances down into the right main stem, which is where it will advance because the right main stem comes off at a straighter angle than the left, then the tube is going to fall into the right main stem. And now, once again, you are fully ventilating the right side and nothing going to the left. It's going to cause your pressures to go up. So Joe, we have 4 correct answers. Which one is it? Well, I'm glad you asked, because the purpose of this video is to show you how details matter. You see, you currently do not have enough information to answer this question. Okay, so if you paused this video and you tried to find the right answer and you went, whoa, they're all correct, then you would be correct. They are all correct, and that's by design. Because I'm going to go to another question just like this, but I'm going to give you more details. Use those details to find out what the best answer is. Here we go. So here we go. You can pause this video, read through it, come back, see if you get the correct answer. We're going to do this 4 times, and the details are going to change slightly each time. So here we go. Same scenario, 36-year-old, 8.0 in the tracheal tube, 22 at the teeth, vent settings are the same, ABG is the same. You get called to the patient's room for the high pressure alarm. This is important. This is the underlying most important part of this scenario. You're in volume control and you get a high pressure alarm. That's the most important part, okay? Which of the following could be the potential problem? Well, now let's look at the details for which they give us. They fall in this one sentence right from there to there. Assessment reveals absent breath sounds on the right with a tracheal shift to the left. That means you have something happening on the right side causing the trachea to push over to the left, and we have hypotension. This screams as loud as possible, tension pneumothorax, and that's the correct answer to this scenario. All of the details in this scenario say pneumothorax. Now, you may be thinking, well, I thought it maybe was obstruction of an endotracheal tube. Well, obstruction of the endotracheal tube should not present with unilateral breath sounds. So it couldn't be obstruction of the endotracheal tube. Why is it not mucus plug, Joe? Because if it was a mucus plug, which will cause absent breath sounds, you will not find a tracheal shift away from that area. You see, a mucus plug will cause atelectasis on that same side. So let's say you had absent breath sounds on the right. That means you're going to have right-sided atelectasis. That's not going to push the trachea to the other side, and it's not going to cause hypotension. So it's not obstruction, it's not mucus plug, and accidental advancement of the endotracheal tube. Well, remember, this is going to go into the right side. You wouldn't have absent breath sounds on the right with a main stem intubation on the right side. So it's not accidental advancement of the endotracheal tube. The only plausible and the best answer in this scenario is pneumothorax, supported by the absent breath sounds on the right, tracheal shift to the left, and the hypotension, specifically a tension pneumothorax. All right, let's change the details just a little bit and look at another scenario. Now, everything is the same. You work through it, you find everything the same. You get your high pressure alarm. Remember, this is the key. Which of the following could be the potential problems? You get details given in this sentence right here. Assessment reveals absent breath sounds on the right with a hyporesonant percussion note on the right. Okay, so we've got absent breath sounds on the right, but we also have a hyporesonant note on the right. Now think about this. A hyporesonant note is the result of increased density on the right side. That will give you a hyporesonant note. It's associated with things like atelectasis, pneumonia, pleural effusion. Things that are associated typically with consolidation or fluid. So we have absent breath sounds on the right, but also hyporesonance on the right. That right there allows us to eliminate a pneumothorax. You see, on the previous question, I could have said absent breath sounds on the right with a hyperresonant note on the right, but I didn't. I could have, but I didn't. that would have indicated a pneumothorax. But now we're saying a hyporesonant. So we know we have something going on the right side, and it's causing an increase in density. Well, again, an obstruction of the endotracheal tube most commonly will not lead to a unilateral finding when your assessment is happening. An obstructed endotracheal tube is not going to lead to absent breath sounds on one side or another. Okay? So it's not obstruction of the endotracheal tube. Mucus plug. Let's think about this. We have a mucus plug. Would we have absent breath sounds on one side? Yes. If you have a right mainstem mucus plug, you would not get breath sounds on the right. If you had a right mainstem mucus plug, would it cause atelectasis on the right? Yes. Why? Because there's no airflow to that right side. Everything is going to the left side now. So remember, we had absent breath sounds on the right, and we have hyporesonance on the right, which supports right-sided atelectasis, which most definitely could be caused by a mucus plug in the right mainstem. Mucus plug is the best answer to this scenario. Now, if you're thinking, well, why can't it be advancement of the endotracheal tube accidentally? And we're going to talk more about this in a second. Well, remember, if the endotracheal tube accidentally gets advanced, it's going to most likely go into the right side. And for your TMC exam, it's always going to go into the right side. I don't know if I've actually ever seen a left-sided mainstem. As a matter of fact, I know I've never seen a left-sided mainstem. I'm not going to say it couldn't happen, but I'm going to say it's most likely going to be a right-sided mainstem. Well, let's think about that. If it's a right-sided mainstem intubation, you would have breath sounds on the right, not the left. So therefore, it can't be accidental advancement in the tracheal tube because we have no breath sounds on the right. So the best answer to this one is 100% mucus plug, specifically in the right mainstem. Now, let's switch it up. Let's change the details here. Everything stays the same. Still a 36-year-old, 8.0, 22 centimeters mark, VCAC, tidal volume 450. Everything stays the same. Blood gas stays the same. You get called to the patient's room for high pressure alarm. That's always a key. Which of the following could be the potential problem? That's the question. The details you're looking for are right here. Now, the reason I make this important is to understand that this blood gas does not determine any of these correct answers. This FiO2 does not determine any of this. Okay? So you have to be able to decipher what matters and what doesn't. Yes, this blood gas, we probably want to fix it, but they're not asking us about that right now. So stick to the question. What is the potential cause of the high pressure alarm? Now, the details right here. Upon entering the room, you observe an agitated patient reaching for and biting on the endotracheal tube. Agitated patient reaching for and biting on the endotracheal tube. And when a patient bites on the endotracheal tube, what it does is it increases airway resistance. In volume control, increasing airway resistance will cause your high pressure alarm to go off, or at least cause your pressure to go up. Maybe your alarm doesn't go off, but it will definitely cause your pressure to go up. Now, nothing here supports a pneumothorax, so we can mark it off the list. Obstruction of endotracheal tube. That's the answer. Why? Because the patient is biting on the endotracheal tube, and this is causing that endotracheal tube to become obstructed. That is increasing airway resistance and the cause of our increasing high pressure alarm. So the correct answer here is obstruction of endotracheal tube. What about mucus plug? Not the answer. Why not? Because we have no evidence of a mucus plug. There's no information here that tells us that we have a mucus plug, just like there's nothing that supports pneumothorax. Well, maybe the patient's agitated because they have a mucus plug. Maybe so, but nothing supports that. They might be agitated because they have a pneumothorax, but nothing supports that. So you have to truly take face value. What information do you have? And what could the problem be? And in this scenario, the problem is the biting on the endotracheal tube is causing an increase in airway resistance, in volume control, causing your high pressure alarm to go off. An accidental advancement of the endotracheal tube, not the correct answer, because again, we have nothing supporting that. So you have to truly break down the details of these scenario questions. One more for you here, and then I'll take questions in the comments, and you guys let me know what you think about this. Same scenario, 36-year-old male, ICU, 8.0, 22 centimeter mark, vent settings, blood gas, called to the patient's room. Most important part, high pressure alarm going off. This tells you what the problem is. This tells you, okay, what's going on with the high pressure alarm? Question is, which of the following could be the potential problem? That's what we have to find the answer to. Why is that alarm going off? Okay, assessment reveals a cuff pressure of 40 centimeters of water pressure with an endotracheal tube now positioned at the 28 centimeter mark at the teeth. This sentence right here is the most important part. It contains the details you need to decipher the answer to the question of why that alarm is going off. Okay? Now, when we look at this, we have to go back to the previous statements in this scenario because there are details in the previous parts that are going to help us answer this question. Remember when we started with a 36-year-old male with an 8.0, we were at the 22 centimeters at the teeth. Now we're at the 28 centimeter at the teeth. So our endotracheal tube has inadvertently advanced 6 centimeters. That is most likely going to result in a right mainstem intubation. That makes the best answer to this scenario, answer D, accidental advancement of the endotracheal tube. Nothing supports a pneumothorax, nothing supports an obstruction, and nothing supports a mucus plug. What is supported is we have an endotracheal tube that has moved from the 22 to the 28, and it's best supported by this answer right here. Now, some of you may be thinking like, well, how does an endotracheal tube accidentally get advanced? Easy. We turn patients, we rotate patients, we resecure endotracheal tubes, and sometimes advancements accidentally happen. It's just part of the game. I've seen it multiple times, many times over my career. So it's not an implausible idea that an endotracheal tube might get advanced accidentally by 4, 5, 6 centimeters. Okay? Our job is to catch it and fix it. Now what happens when we advance that, when that endotracheal tube gets accidentally advanced by 6 centimeters, you see that endotracheal tube go into the right mainstem. This lung becomes atelectatic and all ventilation is happening now in this right lung, and that's causing your high pressure alarm to go off because you're still delivering the set tidal volume. Why? Because we're in volume control. So the answer here is accidental advancement of the endotracheal tube. Now if you were asked to fix this, the answer would be to withdraw the endotracheal tube back to the 22 centimeters mark to where it was originally placed. Now, I want to show you this 40 centimeters of water pressure of the cuff pressure. That's a distractor. That is hoping that you go, my cuff pressure is really high and I got to fix it and I don't know what would cause it to be high, and so I don't know what's going on here. Do we need to fix that? 100%. But is that what's causing the high pressure alarm to go off? 100% not. So yes, there are multiple things in this scenario. The 40 centimeter cuff pressure, this ABG has been jacked up from the very, very first scenario. Should we fix that? Yes, but it's not what the question is asking. So find out what the question is asking and fix that. That's going to lead you to your correct answer. Okay? It's not what you think is the most important. It's what is the question asking. Find the problem. Use the details to discern between one or two questions that could cause the alarm. Now, this scenario was all four of them could be the cause. But you have to discern, say, there's only one of these. When you're taking the TMC, you're going to eliminate it down to probably two answers just about every single question that are very, very close and could be the correct answers. The details will be the separating factors in what the correct answer is and why the other answer is not the correct answer. I want to know what you think about this. Put your comments below. Hit the like button if you found any value in this video. And if you find any value in this channel, hit the subscribe button, turn on bell notifications so you know that when I send out a video later this week, you're going to know. And maybe you'll learn something right along with me and we continue this journey together as we all become quality respiratory therapists. In the meantime, go be great and never ever forget, average is easy, so don't be it.